Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. It is Saturday morning coffee talk. Actually, by the time this gets posted, it may be Saturday afternoon coffee talk. This was the first opportunity I've had in quite a while to sleep in, so I definitely took advantage of it, which was really nice. I've gotten a lot of feedback from people that they really like the coffee talk episodes. So I think that moving forward, I'm going to do one of these weekly. It's going to become a consistent thing. They're easy for me because there's really not a whole lot of research, scripting, outlining that goes into it. I write like 3 bullet points on my Apple Notes here, and then I hit record and I just start riffing. So it's very easy for me. So I like it, like low work, high yield. What businessman would not like that? But I think this is going to become par for the course, if you will. And I am still going to be doing traditional episodes as topics come up in my mind, like the innovation episode I'm going to put out this week. Different topics, obviously, I will do educational content and commentary on them. And then, of course, guests. I love having guests. I love having guests because, again, I don't really need to do much work. I'm being funny, but I do like having guests, and people love hearing what other people have to say because you don't want to just hear me talk. So we'll be doing the coffee talk episodes, topics, and then guests. That's what I think the flow of the podcast is going to be moving forward. One of the things I also want to do, this is going to be more of a long-term project, is I want to do something with this space. I did this over a year ago. I really like it. It's my little podcast space, but I think I want to rework it. I don't know what I want to do yet. I'm not good at conceptualizing stuff. Like I was at Resus X and I'm looking at the show, the lighting, the comedy club atmosphere where the conference was. And like Haney's brain is just so creative. Like he could be an interior designer. He was a musician before. So he's got the brain for creativity. I don't have that, but I want to do something with this corner space here. YouTube watchers can see this. If you're on the audio, I just pan the camera to show the corner, but I want to move the desk and the backdrop to be that corner. That's my long-term goal. So if you have any ideas, DM me because I'm not good at conceptualizing this stuff. The conference circuit is over. It has been great. All good things must come to an end, and I am glad that it is over. It is time to get back to normal life. I love interacting with people. I love meeting people in person. It was phenomenal. I had an absolutely great time. I need a rest. I have become quite the homebody, and my social interaction meter is pegged. So I did crash and learn, and then I worked a bunch. We've been super short on the flight team. So I have picked up a lot of shifts, and super short just because of normal life stuff. It's not like there's any issue happening. It's just people get hurt, people get sick, people have babies. It happens, lots of vacancies. And that's one thing that I kind of have been struggling with over the last few months. It is the balance of setting the boundaries between not working too much, not picking up too excessively, and then balancing that with being a team player. And I'm talking about any small team here, like a flight team or a tactical team, or if you're one of the community paramedics and that requires 24/7 coverage. Anytime you are part of a small team, I do think that you have some sort of a duty to pick up a little extra and help out when needed. Not saying that you should pick up every single open shift or that you should be a doormat, but let's use the flight team, for example. There's a ground 911 EMS side at my agency, and then there's the flight team. You can't, and I don't mean this in a negative way or in a disrespectful way, but you can't just pick a medic from the 911 side and put them on a helicopter. There's only a small group of us. So if one person goes out, the rest of us do have to pick up the slack. So I'm rambling. I've been kind of struggling with how to not pick up too much, but how to still help out. If I figure it out, I'll let you know. If you have figured it out, let me know. But the conferences were great. Crash and Learn was an excellent experience. Resus X was great. Haney did a phenomenal job. I am done with the conference. Well, actually, I'm not. This coming Thursday is Resus EM, but it's a 45-minute drive from my house. It's a half-day conference at my hospital that Haney puts on for the residents. He's invited me to come present something. So I will be driving up and then presenting and then leaving. I'll be out of there by 1 p.m. So it's a nothing burger as far as taxation. But the conference circuit is finished. It has been great. So back to real life. One of the things that we did at Resus X that I want to bring up is we did the live YouTube video. Thank you for those who tuned in. It's available on YouTube. I'm not going to edit it and put it on Spotify. If you want to watch it on YouTube, it's there. It's the first time we've done this. It was me, Nick Gioni, Pullum Toilet. It was a wild time hanging out with him. We did Let It Go at a furry karaoke event. Another story for another time. Me, Nick, Melody, Dan Rao, Shad, who is Dan's friend, who is an NP and former flight medic. So it was the first time we've done a YouTube live. It was not without hiccups. It was very chaotic at the beginning, but once we got our flow down, I think it was all right. I actually watched it for the first time last night just because I had some downtime and I wanted to see how it turned out. I didn't watch the whole thing. I just kind of like skipped through parts to get the Cliff's Notes version of how it went. We were kind of drunk during it. It was a lot of fun. One thing, though, is that apparently ads kept popping up during it. And when I started the live, you have the option to turn on or off monetization. And I turned off monetization because I didn't want people to get interrupted with these ads. Well, it happened anyway. And that is one thing that I wanted to address. I've always said, like, I'm not trying to make a gazillion dollars off of the podcast. I'm not. So I had the opportunity to monetize the YouTube channel. I've reached the threshold for views and hours viewed and likes and interactions. I never expect that I'm going to make any money. In fact, I have, since starting the monetization program with YouTube, I have made so little money that I have not yet qualified for a payout, and the threshold is $100. So if that tells you how much I'm making off of YouTube, it ain't that much, and it's been a couple of months. I don't want people to think I'm being greedy. I learned from another podcaster that, because they were bitching about ads on their stuff, and they said, we didn't want ads, but once you reach a certain amount of interactions, whether you select monetization or not, YouTube is going to run ads. It's just going to happen. So in essence, YouTube's like, hey, you're using our platform, you're getting views, you're getting interactions. We're going to run ads anyway. Do you want to make some money off of them or not? What red-blooded American would not select yes? I don't allow ads to be, you can, I think. This is like Grandpa here explaining the tech. If I wanted to, I could have ads play constantly to try to maximize how much I'm getting. I'm not doing that. I have not selected that, but just keep in mind that when you see ads that break in, I have no control over it. So I apologize if it is annoying. It would annoy me. I will say though, that YouTube Premium is like $11 a month, and that is the best money I have ever spent. There's no ads. It's phenomenal. I love YouTube Premium. It's great. All right, what else do I have on the list? I have a couple of things to talk about. I don't know how much I'm going to ramble today. Let me talk about the high dose nitro and scape thing. This is the last time I think I'm going to talk about this on the podcast for a while, because I'm kind of getting tired of the discussion. There has been a lot of interaction about this. We talked about it on the live. As you know, Nick came on and blew up the internet. I'm actually amazed at how much reach that podcast got, because I know that some big time names in foam ed reached out to Nick and were like, how about you come on to our platform and talk about this and defend your position? I think Nick was a little caught off guard too. Nevertheless, this seems to have become a pretty hot topic. A doctor presented on this at Resus X, and as justification for giving high dose nitro, he presented the same studies that Nick came on to debunk. Two thoughts on this high dose nitro thing, and then on this podcast, I'm going to wrap up discussion on this. One, there is a lot of butt hurt apparently, about this high dose nitro thing. I have seen a lot of medics. It hasn't been doctors as much, although a doctor did give the lecture at Resus X to defend it or to advocate for it. But I have seen a lot of medics in the comments were like, God damn it, this is evidence-based medicine. Look at these studies. This is validated by gold standard research. I kind of don't think that. I do agree with Nick. Whether I agree with Nick on the utility of high-dose nitro or not, the one thing Nick is absolutely right about is that the data is fucking garbage on the use of high-dose nitro. But I have seen a fair amount of medics who did not like being taken out of their comfort zone and being challenged on what they think and do and believe in. And when that happened, the talons came out, like ready for a fight. I see this as a content creator. I can do content where I say, hey, I think ER doctors suck just as much as medics at intubation. And if you truly track the statistics for their first pass success and complications rate, it would probably be on par with paramedics. People will cheer. I can say, hey, I changed my mind about POCUS. I think we should be doing it pre-hospitally. People will cheer. I can say, screw the haters. We should be given paralytics. Screw this SAI. Screw those old medical directors. They need to trust us and give us the tools to do the job appropriately. People will cheer and give me all the dopamine hits in the world, like, share, retweet, rub your inner thighs, blow in your ear, rub their lips on my neck. But as soon as I say something that challenges what we do and say, maybe we shouldn't be doing this, maybe we should reevaluate, is what we are doing really meaningful? Is what we are really doing really impactful? People get really pissed off. And that turns to hate and vitriol. Now, I am not saying that any disagreeing comment is hate or vitriol. No, I talked about this on the last coffee talk. The discussion is good. Differing viewpoints are good. A spirited argument, an aggressive argument counter is good. And I like that. I enjoy it. I kind of view it as a sport. And as you know, with my views on the POCUS thing and how now I don't think that everybody should be doing RSI, I am not close-minded enough that I'm amenable to having my mind changed. I absolutely am. And it's arguments that people like you make that have changed my mind on things. So debate is good, but I see people just getting pissed off and they're like, oh, no, we do high-dose nitro at my shop. I hate that. At my agency, and it's life-changing, it's life-saving, it works. And I have to be like, yo, tap the brakes, homie. Look at how much you're using high-dose nitro. How much are you really using it? Go back through EMS charts and look, how many times have I used high-dose nitro? So you are telling me that with your anecdotal experience of 6 times a year, maybe pushing 1 milligram of nitro, that you are comfortable to go public and stomp your feet and show how pissed off you are that somebody would dare say maybe this isn't good practice. Just when somebody says something that challenges what you think, and I've said this before, so I'm going to drop it after this, use it as an opportunity to learn more and think. The second thing to end this nightmare about high-dose nitro is I must ask, what is the point? Let's just say that the papers that are out there, the Patrick paper and others that say that it is safe, basically those papers say, hey, we gave it, the patients had a drop in blood pressure and they didn't die or get worse. That's basically what the paper said. There did not, to me, appear to be any correlation with mortality, length of stay, impact downstream, how these patients did. All it was, yeah, we got blood pressure reduction and the patients didn't die. That's what I took from it. That's how I extrapolated it. But let's just say that a 1 milligram push of nitro did drop the blood pressure and patients didn't get worse. From my experience, and my experience is pushing 200 to 400 mics IV push, which, to quote an ER doctor I was talking to, and not that he's the grand poobah of anything, but he was like, yeah, that's a very reasonable dose, 200 to 400. And then starting a low dose infusion and titrating up. I think I said on the last podcast, I usually give 200 push and then I titrate up, and I don't think I've gotten past 40 or 50 anytime recently, mics a minute. That works fine. It works great. So my question is, what is the point in going balls to the wall, gunslinger, and giving 1 milligram right off the bat? I don't know if there's any benefit. Why would you do that? You can always give more. Why start so high? Yeah, there are some times you have to be really, really aggressive, like surgical airway first line. Uh, I've said status asthmaticus, I always treat very aggressively right out the gate because I don't want to have to intubate them. There are cases for going balls to the wall as soon as you make patient contact, but in the overwhelming majority of patients, less is more, or starting conservatively and then gradually escalating if needed. I I just don't understand why you would give a milligram right off the bat. Patients get better with the low dose nitroglycerin and the CPAP. They get much better. So what is the goal of the milligram push? I don't understand it. I don't. Okay, enough about this high dose nitro and skate thing. The other thing that I'm going to talk about, which I have also brought up before, is the end-tidal CO2 thing. Now, there were no lectures on end-tidal CO2 at ResusX. I mean, certainly it came up in a couple lectures, but there was discussion I had with other docs, paramedics, offline, like at the bar during breaks, where we were talking about end-tidal CO2. And this is another area where paramedics' talons come out when I challenge the use of end-tidal CO2. I love end-tidal CO2. I love waveform capnography. It is phenomenal. It truly is. On the helicopter, we can give a 1.5 milligram per kilogram dose of ketamine for severe pain. So we can, in essence, knock them down, keep them breathing, just render them docile in an oblivion, treating their pain. It works great. End-tidal CO2, as Aurora learned, is mandatory for that. If I have a fentanyl overdose and I'm not doing the old 2005 2 milligram push, slam it IV. No, we give it 0.4 milligrams, titrate to effect. If I want to wake them up a little bit, just enough to keep them breathing during the transport so that they're ventilating and they're not in withdrawal, end-tidal CO2, waveform capnography. And there are other uses for end-tidal CO2, certainly. I'm riffing here. I'm talking right off the cuff. So I'm sure I'm missing things, but I use end-tidal and capnography all the time. It is a phenomenal tool. But what we have classically been taught about end-tidal CO2 and waveform capnography is simply not accurate. And that is that it can be used as like a poor man's substitute for an ABG or a VBG. And we've always been taught, at least paramedics, that the end-tidal CO2 almost exactly matches the partial pressure of carbon dioxide in the patient's blood, the PCO2, or if you're looking at arterial CO2, PaCO2. And that is true sometimes. That is true in the healthy person. That is true in the 12-year-old who's going for a tonsillectomy. That is true in the 23-year-old girl who's going to get a breast augmentation, or I guess it could be a guy getting a breast augmentation. What do I know? It's 2025. Healthy people don't have a ton of dead space. They have physiologically normal dead space in their lung. And dead space, for those of you who don't know, dead space are the parts of the respiratory system that do not participate in gas exchange. So if air flows through the trachea or the bronchioles, there's no alveoli there, so there's no gas exchange happening. That is dead space. If you have pneumonia, or you have a pulmonary contusion, or you have pulmonary edema, scape, that is filling those alveoli, and it's taking them out of the gas exchange equation. Gas exchange is not happening in those alveoli. That is dead space. So the sicker the lung patient, the more dead space they have. The more dead space they have, if you really want to nerd out, look at the Bohr equation. The Bohr equation expresses the relation of dead space and tidal volume. The more dead space, the less reliable the end tidal CO2 is going to be. And this leads to dumb shit practices like hyperventilating the fuck out of a patient that you have intubated that is in respiratory failure because you want to get their end tidal to 35 to 45 and it was 80 when you intubated them. That 80 is not accurate. I'm just telling you right now. You put end tidal on a status asthmaticus patient and you get a whatever value. I've seen it low because they're hyperventilating. I've also seen it super high. You don't know how accurate it is because there's dead space. They're lung sick. The sicker the lungs, the less reliable the end tidal CO2 is. So you can't use it as an end all be all like they taught you in paramedic school or like they taught you in continuing ed. It's just not the case. End tidal CO2 is great for that patient that you're sedating. It's great for that fentanyl overdose that you pick up from the Frankfurt Avenue bus stop. It is great. I'll say even like you have a 22-year-old who shot themselves in the head, end tidal CO2, it's probably going to accurately match what's the partial pressure of carbon dioxide in the blood. But I would say 50% of the time we use end tidal, we're using it on a respiratory patient of some type. Just keep in mind that it is not the end all be all. I say, and this is just me, I'm just the blowhard paramedic with the podcast, pulse ox and actually staring at the patient's work of breathing and their skin color is a much better respiratory assessment than end tidal CO2 and the shape of the waveform. I've had crashing COPD patients, crashing asthma patients who have not had a shark fin waveform. Paramedic school would make you think like, oh, there's no shark form waveform. There's clearly not bronchoconstriction here. That's my shtick. I really think, and here's my controversial statement that's going to piss people off, and maybe I'll get an angry email from the people who make end tidal CO2. One of my old managers used to work on the side for a company that produced a lot of end tidal products. And he was always kind of a prick. So I hope he hears this. Here's what I have come to believe. End tidal CO2, waveform capnography, freaking great. They don't use it in the hospital that much. Melody and Nick were talking about this during one of the breaks in our little circle. They just don't use it that much on non-intubated patients because of what we already talked about. And there's better monitoring tools out there, like staring at the patient. I think that these non-invasive end tidal companies, this is my speculation, my guess, my philosophizing. I don't think that it took off selling to the hospitals as much as they thought it was going to. So what did they do? They see EMS and they zero in, and there's an impressionable group of people. Let's make them feel really smart and oversell the fuck out of the utility of this stuff. We bought it hook, line, and sinker. I became a paramedic in 2007, and I was team end tidal, like end tidal for everything. You can tell if the patient's going into hemorrhagic shock because their end tidal's dropping. If you need a friggin' end tidal to tell you that your patient's in hemorrhagic shock, then you are standing at the gate and the airplane left 4 hours ago. So I spiced people up, I think, with the high dose nitro and scape thing. And while I was already challenging assumptions and pissing people off, I thought I'd talk about how I think that end tidal and capnography is completely overused. I will never understand these people who put it on every single patient. Oh, it's good patient care. Oh, it's another tool. So every time I have a paramedic student that I am precepting and they want to put an end tidal on, I'm like, all right, explain your rationale for that. Oh, I want to monitor their breathing. Do they look like they're not breathing effectively? They're sitting up and they're telling you about their grandchild's violin practice. What makes you think they're not breathing well? What makes you think that there is any threat to their ventilation status? So I always tell them, and I do this with every intervention, but I really do it with the end tidal CO2 non-invasive waveform capnography because it's become a thing of mine. I make them explain what information they are trying to gain, pertinent positive or pertinent negative, by monitoring the end tidal CO2. And I'd say that 1 out of 10 times I get a valid answer. And I think, okay, valid. Rant over. Next thing I want to talk about is, you all know I love talking about blood. I'm not talking about the Massachusetts thing. I got to present my Crike case to Zaf, who I know and love. I think most of you people know who he is. But also Dr. Dennis Kim. He's a trauma surgeon from Canada. He came out. Actually, he doesn't sound like that at all. He sounds quite American, normal. I'm joking. Sorry, Canada people. He came out. I got the opportunity to meet him, talk to him, and he presented a lecture on blood products, blood resuscitation. Whole blood's best, as you know, but if you have to do component therapy, he said that he thinks that plasma is the way to go. If you had to pick one product to give initially, he said plasma. Also, I like that. I can't remember if it was him or another doctor. You know, I'm on one of the kicks I'm on is that this whole, like, I think warming the blood thing. Warming the blood is great. Warming the blood is best. But if I had to pick between rapidly infusing cold blood into a trauma patient who was dying versus infusing nicely warmed blood into a trauma patient at a rate of like 250 mLs an hour, I'm picking the cold blood every friggin' time. Because actually, if you want, I wrote a whole paper about warming blood and how I think that it should take a backseat to getting the product on board quickly. DM me if you want the paper. Free open access. Maybe I'll do a Substack where I post it. I don't know. But one of the doctors who did the lecture said, yeah, cold blood first, give them a dose, and then worry about warming it. The Q-Inflow is the only device on the market out there that can rapidly administer warmed blood. Unless you have the Q-Inflow, give the fucking cold blood first and then worry about warming it. I was like in the crowd with pom-poms, like ready to like flash the doctor and take off my top for him when he said that. Anyway, so Dennis Kim, great guy. He gives this lecture and he said, if you had to pick a product to give, he would pick plasma. And this is what Dr. Peter Antevi says. He advocates for plasma. Dr. Mark Peel, who I love, advocates for PRBCs. And I listened to Dr. Antevi's position. I listened to Dr. Peel's position. And I think they're both right. I think we should carry them both if you don't have whole blood. So PRBCs administers volume and it administers red blood cells, which carry oxygen, mitigates the effects of hypoperfusion, delivers oxygen to the tissues. We all know this. And this is what many places who give component therapy give, PRBCs. We give that at Medic 94, my full-time job. So Dr. Dennis Kim was saying that in his opinion, more important than that is the volume expansion with plasma, but also that you get endothelial damage in traumatic shock states. So you get vasodilation, the endothelium of the vascular layer gets damaged, it becomes permeable, and the fluid component leaks out of the endothelium, causing worse volume depletion, worse shock, worse hypoperfusion. And plasma repairs that endothelial layer. And he was talking about how critical that is. So backstage, I was like, hey, so if we can only pick one component, just to confirm what you said, plasma's the way to go. And he was like, yeah, absolutely. Plasma's the way to go. Which challenges an assumption that I have had for a while. I would think that PRBCs would be the way to go. Now, did I get mad at him? So like, oh, you don't know. I've given blood 10 times this year. You know, oh, you don't know. No, I think he made a great argument. I hope that this spray-dried plasma thing comes to fruition and that we have it within a year, like I've heard people say. I think that's going to be a game changer because whole blood is expensive. Spray-dried plasma should be cheap. Anyway, I thought it was an interesting topic and I wanted to bring it up because I love all things pre-hospital blood. I have become such a freaking thought, a nerd for pre-hospital blood. So anyway, that is what I have for Saturday morning coffee talk. I think I've rambled a lot. I'm going to edit this. I'm going to post it and I'm going to go about my day. So it is nice being back to real world. It is lovely. I work tonight. I go back to my normal schedule. I actually have a couple of days off this week, which is going to be really nice. Nice to get back into the swing of things. Going to post an intubation episode that I recorded a little while back. So that will be out probably this week. And we have some good content coming up, some good guests and different things on the horizon. So that's what I got. Everybody have a good week and I will talk to you.